p.m. Meanwhile, I request the dignitaries and the experts and the participants to have high tea. Thank you. Good evening, all. On behalf of the organizing team, I welcome you all for this roundtable conference on perspectives on prenatal genetic testing beyond the genome, hosted by AVMC Vinayaka Mission Puducherry campus. I feel extremely privileged to welcome our chief guest, Dr. Anjalakshi Chandrasekhar, founder president, Tamil Nadu Federation of Obstetricians and Gynecologists. Madam has been a past president of Oxy and Dipsy. She had vast academic experience being professor and HOD in many medical colleges, and she has done her PhD, doctorate in pregnancy diabetology from the Tamil Nadu MGR University. She has been awarded with many orations. She has been awarded with Best Doctor Award, Lifetime Achievement Award, etc. She had been the resource person in many conferences. We feel delighted to have you here, ma'am. We welcome you again. I am honored to welcome our guest of honor, Dr. Lakshmi Devarajan, Senior Gynae Consultant, Bilrath Hospitals, Chennai. Madam has wide clinical experience of more than 40 years. She had served in Obs and Gynae, initially as faculty at medical colleges, later had been a busy practitioner with a special interest in women welfare and camps. She is very famous in television. She has delivered many health-related talks. On behalf of the organizing team, we welcome you, ma'am. I feel delighted to welcome our Honorable Chancellor, Dr. A.S. Ganeshan, for this roundtable conference. Sir has been the driving force and motivation in organizing this conference. I welcome Dr. Anuradha Ganeshan, Vice President, VMRF, for this scientific session. Madam has been an inspiration for us always in organizing many more conferences. I welcome Dr. T.V. Devarajan, Member, Board of Management, for this session. Thank you, sir, for joining us today. I welcome Mr. Suresh Sambil, Member, Board of Management, for this session. I welcome Dr. S. Srinivasan, moderator of this session, and the panelists, experts in different fields who are going to enlighten us on this novel topic. Hope the session will enlighten us on the novel and the quite controversial topic on prenatal genetic testing with national, and we have international experts also joining with us today. Thank you. As we move on, now I'd like to invite the chief guest, Dr. Anjalakshi Chandrasekhar, to address the gathering.
Thank you, Dr. Deepa, for that nice welcome address. Good afternoon and good evening to everyone. Respected senior physician Dr. Devarajan and the management of Vinayaka Mission, Dr. Mani Srinivasan and my dear friend Dr. Lakshmi Devarajan. It is a great pleasure and honor for me to stand before you taking participation in this wonderful continuing medical education. My sincere thanks to the organizers and special thanks to Dr. Janani for involving me, and my warm regards to Dr. Mani, who is going to moderate the interesting and informative panel, and his robust panelists who are going to clear our doubts and dilemmas. I just want to introduce this subject. A pregnancy is the time of great anticipation and sometimes anxiety, especially when there is a previous anomaly or fetal loss. So every parent, they longs for a healthy child, but sometimes the nature makes it difficult for them because of the mistakes occurred during fertilization, resulting in missing or extra chromosomes or translocations of the part of the chromosome or microdeletions, giving rise to congenital disorders like Down syndrome, which all of us are very familiar. So for more than 30 years, identifying the women at increased risk of Down syndrome has been the form of prenatal testing, by using factors like maternal age, specific serum analytes, ultrasound findings. Now, with this, evolution has reached a detection rate of 88 to 96%. But since 30 years, of course, recently, the science and technology is advancing so fast, and also the expectations of the parents. The PGT is enormously expanding. There are parallel programs along with this for the universal parental carrier screening also for autosomal recessive disorders, for example, cystic fibrosis and muscular dystrophy, etc. When these carriers are identified, the couples can choose the pre-implantation genetic diagnosis to avoid the affected pregnancies or termination of the affected pregnancy or be prepared for birth of a affected child. So, with recent technological advances in the methods to identify the numerical and structural chromosome abnormalities, point mutations such as chromosomal microarray, which is known as CMA, next generation sequencing NGS, in the screening and diagnosis of genetic abnormalities in the fetus, it is undergoing an unprecedented rapid evolution. The CMA and the NGS have also accelerated the discovery of the cause of intellectual disability, birth defects, and many more genetic and genomic disorders, and the carrier screening, which we can do it 100 screening can be done in one single sitting. This, I went through the literature and I was so much astonished that so much of progress has been made in this genetic science. Okay. There are many more new comings of the test like WES, that is the whole exome sequencing, and chaperone mediated autophagy, another CMA. All these things, they are helpful. They have a role in aging biology, rejuvenation of stem cells, cancer, neurodegeneration. So, reading all these things, I think the whole, the individual can be modified with this genetic and genetic engineering. So, what are the benefits of prenatal testing? They help diagnose the genetic disorders. We can start treatment or initiate preventive strategies, and making life decisions such as the career of the individual and also family planning. Because of screening and diagnostic tests, a number of people who has disorder like Tay-Sachs disease, it has gone down entirely. Dr. Devaraj will agree with me. He will not be seeing any cases of Tay-Sachs disease. Yes, sir? So, of course, this also has disadvantages like the test are slightly increased risk of miscarriage and other pregnancy complications, and patient may feel very angry when you disclose them the result, and also they may be depressed, anxious, and they feel guilty of their results. And this genetic testing creates tension in the family members. And privacy may be lost. In some cases, more family members, they may have to undergo the test. And for whom we have to offer this test, that is very, very important, because you have to be very careful. Otherwise, all this unnecessary trouble, problems, and confusions in the family will come. So, mostly, all pregnant women, now we all of us agree, because once when the Down syndrome screening came, it was only optional. We were doing it beyond the age of 35 years. But now we do it universally, because if you look at the incidence of Down syndrome in 20s, that is when the mother is 20 years old, the incidence is 1 in 1,250. When she is around 30 years, it is 1 in 1,000. Only this much difference is there. Once beyond 35 years, the incidence is 1 in 400. Beyond 40, it is 1 in 100. So now we have, the Tamil Nadu government, we follow the universal screening for Down syndrome screening, both ultrasound as well as the biochemical markers. The Next is when there is this one indication, then next is when there is a family history or a previous child with a genetic condition, you opt for the prenatal screening. And the parents who are known carriers of specific genetic condition, and when there is an abnormal ultrasound findings, or when the screening test is positive, you would go for a diagnostic test. And when there is a previous miscarriage, especially recurrent pregnancy loss, that is usually after 2 fetal loss, or when there is a stillbirth, we go for this prenatal genetic testing. So the various methods are available. Both you have the screening test and the diagnostic test, which may be invasive, non-invasive. I will not go to the detail of that. Nowadays, after the invention of the cell-free fetal DNA, a lot of advancement has been made in the analysis of each individual proteins in the genes. So they have gone to that extent, and they can have the whole horoscope, genetic horoscope they can have. Okay, but anyhow, we have some concerns also, because in this test, they are rapidly progressing. Rare conditions they have included for the adequate clinical validation. So there is a high false positive rates resulting in unnecessary diagnostic procedure, and high false negative rate resulting in missed genetic diagnosis. And so we should be aware of these issues and judiciously use the test, so that we'll avoid unnecessary conflicts. And another thing is the awareness of these facilities which we have. It should be there. We should know, the medical people should know what all the things that are available and how to apply them. That is very, very important. And I congratulate the Vinayaka Mission for taking this step to actually pass on the messages to the medical professionals. I request them to continue this mission, so that our medicos will be updated with the knowledge, and they can give a better service to the fellow patients, fellow women. Okay? So that's what, when I went through the literature, there was advancement of prenatal genetic testing is so vast, and I am sure it will become a subspecialty in obstetrics in the future. With these few words, I once again thank the organizers for this opportunity, and thank you once again. Jai Hind.
Thank you, ma'am, for that nice overall introduction to prenatal diagnostic and testing. Now we'll move on to the scientific session, panel discussion on perspectives of prenatal diagnostic testing. And we have Dr. Manish Srinivasan, ID Consultant USA, to moderate this session. Dr. Manish Srinivasan graduated from Stanley Medical College, Chennai, with a postgraduate training in internal medicine at United States. And he had underwent advanced training in infectious disease at Columbia University. He has been with the Office of Medical Services at United States Department in Washington, D.C. Now I'd like to invite you, sir, to start the panel discussion. Yes, sir, the stage and the screen will be yours.
Distinguished colleagues, first of all, I want to thank. Can you hear me? Okay. Good afternoon. Thanks for joining here in person, and people who are joining online. First, I want to congratulate Vinayaka Mission Chancellor and his team for making this event possible, because this is one of the making this event possible. Without much delay, I would like to invite our panelists, Dr. Radhika Ramesh. Is she here? She's a senior consultant in the Department of Fetal Medicine at MGM Hospital and also director of Raju Hospitals, Chennai. She has more than 15 years experience and her areas of expertise include fetal imaging, perinatology, fetal echo, and fetal interventions. Prior to specializing in a chosen field, Dr. Ramesh trained as an obstetrician and gynecologist and has served as a medical college faculty in the past. She is a member of the Society of Fetal Medicine Tamil Nadu chapter. Now, switching from India to the US, we have Dr. Rajivi Madan Kumar, who's also a great family friend of ours. She is an associate professor of medicine at Hofstra University and a prenatal geneticist and an attending physician in the Center of High Risk Pregnancy and Fetal Health. She is the architect behind the prenatal genetic counseling program at Long Island Jewish Medical Center, which impacts patient care and collaborating with genetic services. With a strong commitment to education, she actively trains sonographers, medical students, and contributing significantly to the field's achievement. Her groundbreaking research contributions, including the published case study, showcase her as a prominent figure in prenatal diagnostics. Those of you who want to know more about her, you can Google search. Another feature is that she's a graduate of Madurai Medical College, and we are proud to have a person of Tamilian origin there. Next one is Dr. Deepa Thangamani, please. Please join. Welcome, Dr. Deepa. She's a distinguished OB/GYN expert in Chennai, holds over more than 15 years of specialized experience. She practices at Apollo First Med hospitals in Chennai, and Dr. Thangamani offers comprehensive care encompassing prenatal consultations, high-risk pregnancy management, fertility guidance, women's health issues, and personalized birthing plans. Thank you for joining us. The next one is tough. Dr. Bhavani Srinivasan, please join us. She's a US trained physician and formerly medical director of children with special needs, Suffolk County Department of Health. And she has practiced pediatrics over 30 years. She has been emphasizing the need for screening for non-communicable diseases, namely genetic disorders, using the state-of-the-art technology to help prospective parents. The next one is, can I have request Dr. Alec Correa, please join us. The consultant medical geneticist at Apollo Hospital, Apollo Proton Center, and has a rich background in clinical genetics. And he has previously served as an assistant professor at Institute of Liver and Biliary Sciences, New Delhi, and a research officer and resident doctor at the All India Institute of Medical Sciences, New Delhi, and a medical dentist at the LifeCell International. He's very passionate about applying genomics in clinical settings. He investigated the use of exome sequencing in the evaluation of non-immune hydrops fetalis for his DM thesis. Is Gabriel there? Okay. Gabriel Lazarin, welcome, Gabe. He is the Vice President of Medical Affairs at Myriad Women's Health, which is part of Myriad Genetics. And they have offices in California, and they have been providing exemplary services. And he leads a team of genetic counselors and nurse practitioners that perform provider education, clinical research, and publications. As one of my earlier speakers mentioned, that the purpose is to make awareness of illnesses that are hidden, and so bringing the care to the masses in a way so that it is not meant only for the exclusive, well-affording rich people. So it is, it's only these tests will be breakthrough. And his experience in carrier screening began at Council, where he was an early employee and the first genetic counselor as the company introduced the first expanded carrier screening test. He has delivered talks and collaborated with other screening experts in the US and also worldwide. Thank you, Gabe, for joining. Dr. Janani Dakshinamurthy, please join us. She is the founder and geneticist of Gene Aura Private Limited. She is a very enthusiastic geneticist and genetic counselor for many private hospitals across Tamil Nadu. Dr. Janani is the holder of prestigious Women's Scientist Scheme awarded by the Department of Science and Technology, Government of India. She is also certified by the Board of Genetic Counseling Level 2 in the US and India. Thank you, Doctor. Dr. Sashikala, is Dr. Sashikala here? Please join us. Dr. Sashikala is a medical professional with a rich academic and professional journey. She is graduating from Madurai Medical College. She served at Government Rajaji Hospital and she became professor and head of the Department of Gynecology at Government Training Medical College. Before retirement, she has held many roles at Vinayaka Medical Mission and Hospital, and she works as a professor of medicine at Arbade Veedu Medical College and Hospital in Pondicherry. She has contributed extensively to the field of and being a Senate member of the Tamil Nadu Dr. MGR University and a PG Board of Studies member of Pondicherry University and diligent examiner in multiple states. We wish to welcome all of our panelists and let's start without much delay. Sorry. Okay, that. We should toss a coin or toss. Yeah. Dr. Sashikala, could you comment on the landscape of prenatal genetic testing with the regulatory framework? With the diverse healthcare landscape in India, could you provide us an overview of the current status and trends in prenatal genetic testing?
Excuse me, ma'am. You can be seated.
Yes. From the Indian perspective view, the common causes of a postnatal fetal loss, which causes the disability, they are trisomies, aneuploidies, especially trisomy 21, and single gene defects such as sickle cell anemia and thalassemia, and congenital anomalies, especially the neural tube defects. These are the three common things as per our Indian population. Of all the aneuploidies, we are much bothered about the trisomy 21 or the Down syndrome, because although trisomy 18 and 13 are there, they are rare, and it is only trisomy 21. The individual will be born and it will with an intellectual disability, impairment, and with a normal lifespan. So they have to be taken care by the family members for a long time. And believe me, every year in India, 21,000 babies are born every year due to Down syndrome. This could be easily avoided by doing a prenatal screening, especially in the first trimester. And now we are focusing between 11 and 13 weeks and 6 days of gestational age. We are doing an ultrasound. Apart from measuring the CRL, we are measuring the NT and also the other parameters such as the nasal bone, the ductus venosus, and the tricuspid regurgitation. And routinely, we are doing the double test, which increases the sensitivity to about 80% to 85%. When these patients, when they miss the first trimester ultrasound, when they are coming round about 18 weeks of gestation, yes, we are doing the quadruple test. And by doing this quadruple test, the sensitivity increases to about 80%. And when you're going to integrate these two, the sensitivity goes above 90% or 95% with a false positive of just 2.5. Of late, the addition in the diagnostic test is the NIPT using the cell-free fetal DNA. The trisomy 21, the detection rate by using the cell-free fetal DNA is almost 99.4%. And trisomy 18 and 13 is almost 98%. Now, why we are not bothered? We are much bothered only about trisomy 21. It is because trisomy 18 and 13, most of the fetus will die in utero. Most of them will be miscarried, and even if they are born alive, they have a short lifespan. So the grief is brief. Whereas in the Down syndrome, the individual has to live for a long time, and the whole family has to take care of it. And moreover, when we are doing an anomaly-targeted ultrasound, which you say is the genital sonogram or the targeted imaging for congenital anomalies, TIFA scan, the trisomy 18 and 13, we will easily pick up. When we have an holoprosencephaly, or an ophocele, or a duodenal atresia with a polycystic kidney, or a congenital heart disease, definitely we will think of that. When we are going to get other features, such as a diaphragmatic hernia, or an ophthalmocele, or a skeletal defect, we will think of a trisomy 18. Whereas in trisomy 21, the ultrasound findings are subtle. They are called only as a soft markers unless the ultrasound is being done by a trained sonologist. We will likely to miss the diagnosis because it will cause only a mild ventriculomegaly, an echogenic focus in the heart, an echogenic bowel, or a mild dilatation of the renal pelvis, which is likely to be missed. And that is the reason why we are much bothered about the trisomy 21, and we could easily pick out by doing the first trimester ultrasound. Although we say NIPT is the latest addition with a good level of accuracy, still it is a screening test. The decision cannot be taken by your NIPT alone using a cell-free DNA, and she has to undergo a diagnostic test, either a CVS or an amniotic fluid. The next common cause, the thalassemia and the sickle cell anemia, which is an autosomal recessive trait, or a single gene disorders. We know India is the capital of thalassemia. Every year, 9,000 babies are born with thalassemia, and especially Gujarat, Maharashtra, Punjab, Sindhu, all these places we get mostly sickle cell carriers, thalassemia carriers, and sickle cell anemia is common in mid-India, a small portion in Tamil Nadu and Kerala. So, whenever the parents or the couple, they are known carriers of sickle cell anemia or thalassemia, we need a CVS or an amniocentesis to find out whether the child is affected or not, and then a decision has to be taken to prevent the incidence. And the last one, the common cause, which is a structural anomaly, is we think of the neural tube defect. This defect anencephaly, by doing a non-invasive ultrasound in the first trimester, 100 patients, babies of anencephaly, can be diagnosed even in the first trimester, around about 11 or 12 weeks of gestation. By 18 to 20 weeks, other neurovascular defects such as the spina bifida, as well as by looking at the lemon sign and the banana sign, encephalocele and meningocele can be diagnosed and appropriately treated, or we can terminate the pregnancy so that we need not give a challenged child to the couple. So, in India, the prenatal screening by ultrasound is cheaper and it is easily available all over, whereas the genetic lab are very few. The genetic lab offering the genetic testing, they are situated in only, it is not a homogeneous one, it is heterogeneous, it is present only in metropolitan cities where every population, every low risk population cannot afford. And this genital lab is very costlier, and there are only few persons who are expertise in it, and And our part, the healthcare professionals, we need a proper pre-testing and a post-testing counseling, which we lack, and also the lack of awareness among the public regarding the test. And moreover, regarding the economic level, it is of variable level. So all people cannot afford an NFT, which cost about, you all know, 50,000 rupees. Okay, so this genetic lab has to be established, at least in some of the centers, at a cost-effective manner, so that we can improve it. From the Indian perspective, I think a day will come when this screening test will be incorporated in our general antenatal care. I hope so. Thank you.
Thank you, Dr. Shashkila. Can you hear me? Thank you, Dr. Shashkila. In the interest of time, we request other speakers to talk for about 5 to 7 minutes. And I'm taking the liberty of asking Dr. Rajivi Madan Kumar, because she's in a different time zone. And Dr. Rajivi, please join us. And as I already said, she's a pioneer in the field of maternal fetal medicine. And Dr. Rajivi Madan Kumar.
Good morning, everybody. It's 6:30 in New York.
Okay.
I hope I can all hear me. Can you hear me?
Please share your experiences.
Can you hear me, Dr. Srinivasan?
Yes.
You can?
Yes.
Should I speak louder or no? Fine. Okay, thank you. I'm not going to take a lot of time. I was there in India 2 weeks ago, and I attended the conference in Hyderabad. Even though I'm from Madurai Medical College, I still want to come home. I want to bring whatever I see here to my own home country. Yeah, that is my, I don't know whether it's going to happen. It's my goal. So I try to travel once a year to India to talk. So we all talked about Down syndrome, carrier, single gene disease. And what my goal is to bring to India would be number one is carrier screen. And knowing the Indian culture and, there's so much of consanguinity in India, and even like it's all inbred in one, like they are inbred in one area, the one test which may not be very expensive, which, I don't call the labs and find the prices of individual tests. My counselors do that job. But what I think the most beneficial would be implementing carrier screen in all antenatal clinics in India. I don't know how much it will cost. Now the panel goes to 500 diseases. Most of them are autosomal recessive diseases. Some of them are X-linked. And you can avoid a lot of disasters. It's not just Down syndrome. Down syndrome is the most common aneuploidy. But if you look at the single gene diseases, based on what the carrier status is, now we are talking about beta thalassemias. You can identify a carrier by doing electrophoresis, hemoglobin electrophoresis. But if you do the carrier panel, you can identify very bizarre diseases which is still run in the population anywhere all over the world. Some diseases may be more common in Jewish population, some diseases in Indian population, but doing this panel, you can simply identify carriers, and you can offer testing, or you can go for IVF and PGT. So carrier screen, I'm not sure it's available in India right now. Myriad, Mr. Lazarin, I don't know whether you can bring the services to India for a good price, and it will be very nice to see the population using the test. That would be amazing. Dr. Srinivasan and yourself can try to do that through this big mission. That is carrier screen. And I have some slides to show what are diseases you can avoid, like Duchenne muscular dystrophy. You can avoid thalassemias, as I said, beta thalassemias. So I'm going to shift to next speech to NIPS. And we spoke about sonogram, double test, triple test, quads test, contingent screening, integrated screening. If you can afford to NIPS, you forget all the sonogram. You don't need to spend money for 10 weeks gestation. You just do a blood test. The NIPS is amazing. And it's not just Down syndrome. We are picking up so many bizarre things through NIPS. which I can't even explain. The last 2014, we started doing it. 2015 onwards, now we are seeing so many advantages of doing NIPS. Again, I don't know how much it costs to do NIPS. 10 weeks, you just do one blood test, 99.9% sensitivity for Down syndrome. 18 and 13, 80 to 90% sensitivity, but as the previous speaker said, it's going to be, you're going to pick up those for a lot of anomalies, and they are really short-lived. But again, women going through pregnancy with an abnormal baby, if you know 18 and 13, you don't need to go through the whole pregnancy. You counsel them. I know, termination is very well accepted in India for abnormal pregnancies. That is my understanding. But definitely doing NIPS is a lot more easy to counsel, and very easy. When you look at the time and also the efficiency, NIPS is the best test for major aneuploidies. Coming to NIPS, now we can do genome NIPS, which is actually looking for deletions and duplications, even though it's not the best test. Say if you see an anomaly at the 18-20 week sonogram, you can do amniocentesis, you can offer more invasive testing options, but if you can do NIPS, start with the NIPS at 10 weeks, and then do a sonogram at between 12 and 14 weeks. You can identify major anomalies like anencephaly. You can look for even heart problems, and then you do the anatomy between 18 and 20 weeks. We actually have a very integrated service, like I can't even explain how much we advanced in the last 15 years. I'm working in my facility for the last 15 years, and I see enormous improvement in genetics. I'm so happy to live in a time zone like this to see so much evolution in genetics. And I'm a board certified OBGYN, but I don't really deliver babies anymore because I'm so busy with my genetic stuff, with the prenatal diagnosis. But seeing all these problems, and also I serve a population of very mixed race and their ethnic background. So with all those, NIPS is very advantageous if you can offer to all people. Carrier screen, I would highly recommend for our people, which is going to help with a lot of single gene diseases. Then going to next for genetic invasive testing. Instead of just doing karyotyping, I'm not sure you have access to microarray. And if you see anomalies on the sonogram, especially common things are cardiac, and you see things like renal abnormalities, anything that you see, definitely the patient will gain more out of more invasive testing options like microarray. We are into genome sequencing now. Microarray, if I want to simply explain, like I explained to the patients the way I explained, if aneuploidy, major aneuploidy, like trisomy 21, there is an extra copy of whole chromosome, deletions and duplications, you have a missing portion of the chromosome or duplicated portion of the chromosome. And it's what anomaly I see on the sonogram is the tip of an iceberg. If I see a cardiac anomaly, say, for example, tetralogy-FLO, it's not just like tetralogy-FLO, you can fix it by surgery. You do amniocentesis, you do microarray, you say for the 22q deletion is the most common, deletion. And you can counsel the patients, it's not just cardiac anomaly, it's going to be more attached to it, intellectual disability, developmental disability, et cetera. So that is microarray. Going to exome and genome sequencing, that is more advanced. And if you can find an answer by microarray, the next step would be exome. And if you have access to genome, which is in the research, actually this year we had participated in research by our sister hospital, Columbia Hospital, and we got a lot of hits by genome sequencing. So invasive testing options would be microarray, genome sequencing, exome sequencing, depending on what I see. And one more minute on this. Just a little story behind, like a little story of a patient I saw. Patient is Indian background. She's a PhD, very smart, very knowledgeable. She's a PhD. She came to me in 2017 for genetic counseling. She was like, something bothered her. She was pregnant with her first child, and her husband is Italian background. So they're completely different backgrounds. And that time around, she came and she was asking about the carrier screen to us. And, that time, I think we had the panel covering about 300 diseases. So we did the carrier screen, we did the NIPS test. Everything came negative. Her anatomy was totally normal. And the pregnancy was complicated by a small baby. So we followed her. She delivered the baby full term. And I forgot about her. I saw her during pregnancy. I totally forgot about her. I saw her again at 2022, 4 years later. She again comes to my unit, and she is with the same genetic counselor. I had a session with her. This time she says, Dr. Kumar, I don't know whether you remember me. She was so mad at me, very angry. I said, like, you know what, I don't remember. We see a lot of patients. Then she kept explaining to me the first baby, which was born at full term, which was small in size, started having issues with the milestones, delayed milestones. And then at the age of 8 months or 9 months, by genome sequencing, they found out the baby had a condition called progeria, which is early aging, and which has very devastating prognosis. So when I saw her 2022, she was pregnant with a second child. Now she knows she's a carrier for an autosomal recessive disease, and the husband is also a carrier for the same disease. They are from two different backgrounds, two different countries, ancestors, and they are sharing the common gene, which is a devastating disease. So this time she went for IVF, had a PGD, had a normal embryo transferred. And we had to explain to her, okay, you know what, then when we did the carrier screen 2017, the panel didn't include the gene. But now we have a 500 disease panel. So now the panel has the gene that she is positive for. It was unfortunate, but she went to the point, like she opened a foundation, and she opened a foundation for progeria, and her baby passed away last year. Just a little story. This could have been easily avoided if we offered the carrier screen, but even she had it, we didn't have the disease gene in the panel. By offering carrier screen to all population, whether they are consanguineous or not, if they're from the same country or not, we still can pick up a lot of carriers for autosomal recessive disease. And I think it's 5-6 minutes mark. I could conclude my talk by this.
Thank you, Dr. Rajivi, and thanks for sharing your experience. Only one question is to how do you see all these emerging technologies helping patients and the future of prenatal genetics? Is it a cure or a curse, or a problems or a promise? Hello, can you hear me? Oh, she muted, is it? Okay, all right. I think we'll come back when she comes back, and I think in all fairness, we should give a round of applause at the very end. Okay. Oh, okay, and she can't unmute. Okay, maybe somebody in the tech sector can help her. Dr. Rajivi, can you hear us?
Yeah, I can hear you now.
Okay.
Yeah, I wasn't able to unmute.
Okay, all right.
Yeah, so what was the question again, Dr. Srinivasan?
Yes, how do you see all these emerging technologies to shape the future of prenatal genetics? Just summarize it in a minute or so.
Yeah, okay.
Please.
So when I started in 2007, I did my fellowship in genetics. That's the time the genome sequencing came. And then from that time, next gen sequencing and carrier screen, it's evolving area. And I do see, because I live in New York, we have access to pretty much everything. I do see, like at this point, the patients sometimes the very subtle findings, they come to us, and I can't give an answer for all the possible testing. Now we are finding more answers. I had a patient with a very minimal pleural effusion 2 years ago, nothing else on the anatomy sonogram, minimal pleural effusions. My baby was like lagging by a week. She went ahead and did amniocentesis. We did this genome sequencing, and then we found she is a carrier for very, very, very bad fatty acid oxidation disease. So then she went for IV. She didn't go for IVF. She conceived on her own. Then we did amniocentesis, and babies were unaffected. So it is evolving. The genome sequencing is in the research. In actually this year, we participated in a study by Columbia in the city, and we got so many hits, positive tests for those patients with abnormal findings, where we can't find an answer, but we are finding answer by genome sequencing, which is the ultimate as of now for the prenatal diagnosis. And it is going to come into practice. We can do exome sequencing. Just to explain what exome sequencing and genome sequencing, exome is one, we are just looking at the exons, and which has the coding genes area. Genomes, it comprises of the whole entire genome, which is exons and introns, which is very comprehensive. And depending on what anomaly we see, sometimes the families go through multiple pregnancies are the same abnormal finding. I do see a lot of Pakistani couples. Believe me or not, Pakistani couples, 80% consanguinity in Pakistan, 80%. To the point, like sometimes I see couples with the same anomaly again and again and again. You do whatever test, you can't find out what is going on because some of the single gene diseases, we don't know what gene is causing. But now with the whole genome sequencing, by doing the tests on the trios, which means the fetus, mother, and father, we can identify what gene can cause this recurrent anomalies, and then we can help the couple. We are doing it. And it's just, I am so fortunate to live in this era and with a high genetic, all genetic testing that you can think of, we can do it, and I have access to it. So I really want to bring some of these to India if possible. And definitely Dr. Srinivasan can assist with the carrier screen. I think we should start with the carrier screen and then NIPS and then invasive testing options. The labs have to be able to, I don't think it's impossible, but I don't know the price line. I actually have no clue about the price line. It will be amazing to help couples who want to have healthy children. And it is evolving, and more and more of labs which can do all the testing in regional areas in India should be able to help the population.
Thank you, Dr. Rajivi. Can we give a round of applause for Dr. Rajivi for sharing her thoughts? And she has got a busy day. I think she must have be heading to the operating room soon. So, and it's very cold in New York. So let us give her a break. Thank you, Dr. Rajivi, for sharing your experience. Let's get Gabriel Lazarin. Gabriel, I think you're still awake at 4 o'clock in California time. Gabe, can you hear me? Oh, okay. Gabe has...
Okay, can you hear me now?
Yeah, okay. Gabe,
Okay,
we want to ask
great,
you,
yes.
Your time will be 6 minutes, and we want to ask you, you have a worldwide experience. How do you find the role for standardized genetic testing, and what was the pushback and headwinds you faced, and how do you think the critical need for standardization in genetic practices, and any experiences in the international collaboration in this regard?
Sure. Well, thank you for inviting me to speak on this. And yes, it's 3:45 in the morning here in California, so hopefully I can say things that make sense to everybody. But yes, so the first thing that I'll say is you probably are not surprised to hear that the practice of prenatal screening is very different from country to country. And there are certain countries that have very well-developed prenatal screening programs, such as Israel, the United States, some countries in Europe, and then others that are still, very much progressing. Even in the United States, there are very disparate practices. It's very variable. Where you just heard Dr. Madan Kumar speaking from in New York City, we see that there is extensive genetic testing, extensive genetic screening using all of the latest technologies. In other parts of the United States, the less metropolitan areas, you see that there is very little screening, very little uptake of testing, and a lot of cautiousness about the newest technologies. There are no international societies that, at least with authority, that issue guidelines, of course, for every country. There is the International Society of Prenatal Diagnosis, which has made a very positive statement about cell-free DNA testing for common aneuploidies like Down syndrome, and endorses that. They have not made comments about carrier screening. And then in the United States, one of the most influential organizations to issue guidelines on cell-free DNA screening as well as carrier screening is the ACOG, which is the American College of Obstetricians and Gynecologists, but also a lot of people also listen to the American College of Medical Genetics and Genomics, the National Society of Genetic Counselors, Society of Maternal Fetal Medicine Physicians. So there's a lot of organizations that do weigh in, and even these different organizations have differences in their recommendations. So there's still a lot of, of work to do to create consistency, even within countries, but certainly across countries. One thing that I've learned, though, is that when we're talking about screening, I think there's a few lessons that I've learned over the years, and that I think we can all consider. One is that we need to adjust the testing for the population. So one thing we very much learned from carrier screening is that carrier screening has been done in the United States for 30 years, but it's been done in a very targeted way that actually did not benefit a lot of patients because the conditions were not targeted for the populations being tested. There used to be that you just tested for cystic fibrosis, and it was a very small variant or mutation panel that ended up not catching very much carriers if you weren't of European ancestry. Now, with expanded carrier screening, as was said earlier, we're catching many more carriers and, more importantly, more couples that can benefit from this information. But that has to do with learning more about the conditions that are prevalent in a population, and then the variants that are prevalent in that population. I read a study recently from 2020 about a carrier screening study done in New Delhi, where they found a relatively high number of cystic fibrosis carriers, but for uncommon mutations, at least mutations that are uncommon in the United States. And then there were also a higher number than expected of carriers of Pompe disease, which I'm guessing is not prominently screened currently in India. And then, of course, thalassemia. So there's a lot of opportunity when you adjust the testing for the population. Another lesson is that as you do more testing for all of these things, you're going to find more carriers. And as you do more cell-free DNA testing, especially as you start looking at microdeletion syndromes, you're going to find more positives on that as well. It's important to have a follow-up plan and a follow-up structure that allows people to be informed of those results and allows them to make decisions based on those results. That can be a barrier to truly implementing widespread prenatal screening and carrier screening. But the good news is that there's a lot of technological solutions that can help resolve this. I don't know all of the resources available in India, but we've been able to work with areas that are more under-resourced in the United States through telehealth and telemedicine options that allow more access to genetic counselors and genetic information so that you can reach more patients, because there are many parts of, even with as many genetic counselors as we have in the United States, there's a lot of places that have very, very few. And we find that there's a lot of telehealth options that are able to help fix this. So ultimately, I think these are some of the big lessons that we've learned over the last several years. Ultimately, we do find that patients, when they access this testing, even if they receive news that is difficult to hear, they tend to appreciate the opportunity to at least think about what their options are, think about what types of preparation might be available in terms of potentially delivering having a more successful delivery, or having other resources, perhaps delivering in a certain type of hospital setting. So people appreciate those types of opportunities if they have the chance to access the test. So I'll stop there, but I'm happy to continue to speak on lessons that we've learned over the last decade or so of this testing.
Thank you, Gabe. Give a round of applause and catch up some sleep. It's only, have you had a cup of coffee yet? No, not yet, right? Okay.
Yes, I have my tea here.
Okay, all right. Thank you, Gabe. We will connect with you later on, and thanks again for sharing your experience, and get some rest. You have a long weekend today? I know. Right. Okay. Next, moving on, let's keep our time as much as possible, but the interest is great, but the time is somewhat less. So I'm requesting Dr. Radhika to come and talk about awareness among the clinicians. What are your insights on the current level of awareness among clinicians regarding prenatal genetic testing? And if so, how do you perceive the importance of prenatal genetic testing and potential impact it could have on patient care and outcomes? Please share your thoughts about this.
See, the awareness is the most important because I'm also an obstetrician who do not do deliveries now. I primarily look at the fetuses, prenatal genetic testing, and further on. So when I move totally to that side, the awareness to the clinician, what they think and we think becomes a totally different entity. So first of all, the awareness of what is a screening test and what's a diagnostic test. So most of the time I get the feedback is saying your screening is normal, your scan is normal, and now after birth the baby has got a problem. So the awareness of what and why the test has been done, what is the outcome of the result, the clinicians are not aware. So first of all, what is a screening test and what are the limitations of the test and what's the sensitivity of the test and what are diagnostic tests which we can offer to the fetus and what are that limitations, like what diagnostic, like madam was talking about trisomies. So when we do an amnio for a screen positive woman and it comes as the karyotype is normal. So we are just looking at the gross karyotype and we primarily screen for the common trisomies. So we are now just ruling out that problem. So there's so many single gene disorders and so many other evolving problems which occur later. So the awareness, like once that is done, everything is fine, the outcome is going to be good. So I feel the awareness of limitations of the test which we are doing is a main drawback. And of course, carrier screening is still, many of the clinicians are still not, maybe they are aware, but still it's not put into practice. Maybe because of financial constraints and other things. And what I feel is most of the time I get a referral from a clinician saying the couple are consanguineous couple. So do something about it. So they come for an NT screening. Like I screen them like any other couple who's going to walk, whether they are consanguineous or not. So when I can't look for all the autosomal recessive disorders in that particular couple, and I'm just going to do a scan looking for the phenotype or a structure of the baby and do a screening for a common chromosomal abnormalities. So when they refer and I do a screening for common trisomies and I look at structural problems in the fetus, and I'm only doing part of the whole story. So when I go back to the family history also, I may not be able to give an answer to the couple of what's going to be wrong in the couple. So that awareness, I think most of the clinicians, because when they come with a lot of expectations, I'm consanguineous couple, do something, find out something, assure my baby is normal or not. So that's the main thing. And regarding the NIPS, which all of us are discussing, I think now liberally we are offering NIPS to everybody, whether it is intermediary risk or high risk, screen positive. But in the NIPS, again, we are only focusing on trisomy 21. Even 13 and 18 are taking a little backseat, and everybody is aware that 18 and 13 babies do not survive. They have multiple structural abnormalities, so it's hard to miss anything. So trisomy 21 is the primary target for NIPS, and the sensitivity is as high as 99. So when and also in like Dr. Rajivi, she was talking about NIPS is done at 10 weeks in US and then followed by NT scan. Here we follow, like we finish the NT scan, look at the detailed 11-1 anomaly scan, make sure there are no major abnormalities like anencephaly or holo. Then we go for an NIPT. So we must, most of the clinicians should be aware that the NIPT applies only when the baby is structurally normal. And if there is any structural abnormality, NIPS does not apply and we have to go for invasive testing. So the awareness, I feel, in these areas, if the clinicians are more aware, then interaction with the maternal-fetal will be better and the patients would be benefited. Okay. That's my 2 cents. Thank you.
Thank you for sharing your experience. As we can we move on to Alec Correa on the ethical considerations in genetic testing. How do you since there are so many complexities of genetic testing, is to address the ethical dimensions. Could you tell or share your experience, perspectives? What are the guidelines you think we should be in place to navigate it? Thank you.
Hello. Yeah. Yeah, I think this is a very important topic and often overlooked. So, looking at ethical aspects of prenatal genetic testing, I think the foremost, most important thing is the counseling we give the patient. It should be non-directive, it should be neutral, and it should encompass the latest knowledge about a topic, and it should enable the patient to make an informed decision after receiving that. And as clinicians, we should not try to impose our biases on the patient. That's very important, because the patients come from different socio-religious backgrounds, and their way of thinking might be different from us. Their experience might be different. So it's important that we don't bias them. Another important consideration is a lot of commercial labs do offer free genetic counseling as part of their service. But we should also be aware that that might be biased in that they are driven by commercial aspects, so they might recommend tests which might not be useful for the patient. Another thing is that we should take informed consent, because it is just not just any other medical test. It comes with a lot of implications, both medical, social, familial, and financial implications. And so the patient should be properly counseled about all the aspects of the test and the limitations of the test. I think that's very important. Often I have patients presenting with their child with a disorder during childhood, and then they say that we were tested during pregnancy. And when you go back to see what they were tested for, they've undergone an NIPS, and they say that that clinician told them that all genetic disorders are covered in that. So that is a wrong impression. So the patient thought they're going to have a normal child, which is wrong. We should convey the limitations of the test up front, so that the patient knows what they are getting into and what are the future risks, what risks are possible. Another important aspect is choosing the right test. We should, as clinicians, we should be aware. See, genetics is a rapidly evolving field, and we should be aware about what are the new tests which are coming out, and also what are the indications for the test and limitations for the test. And we should choose the right person to be tested. Often the wrong person is tested. Previously, I worked in a diagnostic lab, and there, instead of the affected child being tested first, the family has presented during the pregnancy, and directly the fetus has been tested. It becomes very difficult to interpret a test in such circumstances, and could lead to devastating outcomes. I've known situations where a fetus, because the lab has got a test directly out of fetus without the proband being tested, the lab has reported a variant of unknown significance, and then the family has gone and terminated that pregnancy. And afterwards, the carrier screening of the parents was done, and actually found a pathogenic variant in another gene, which this fetus was not a carrier for. So they terminated a normal fetus. So that it can lead to bad complications, and also that could lead to a legal issue. So that then the patient was really upset, and they wanted to take legal action. So that's very important. It's also important to consider what disorders are we testing for. So it's well established that severe and moderately severe pediatric disorders should be tested for, like if you're offering carrier screening or prenatal. Also, adult onset disorders which might not have treatments, or cancer predisposition syndromes might be tested for. However, testing should not be offered for conditions which are mild, or also for, now possibly inherited traits, and all patients might come asking for testing for that, which should not be offered. And finally, we should pay attention to the privacy and confidentiality about testing. Often we do pick up results which might affect other family members. So we should have discussions with the patient about how they should, about them disclosing their test results to other family members, because it might affect the health of other family members. At times we do pick up issues of non-paternity. I've had a case where in the testing we noticed that the markers were not corresponding to the father, and then on the post-test counseling we brought up this subject very with the mother in a very confidential way without the husband being there, and then she did open up and say that the husband is not the biological father and he doesn't know about it. So these kind of issues might come up when you do genetic testing, which should be kept important. And finally, there are other implications, like now a lot of some financial implications might be there in the fact that some of the insurance companies might try to deny claims if they notice a genetic diagnosis written in the file. There are a number, although the Indian government recommendations say that genetic diagnosis is not an exclusion for insurance coverage, but there have been instances of that, so that has also to be kept in mind. And finally, interpreting genetic results can be quite challenging in the prenatal setting, because we get only a partial phenotype, and we are also bound by time limitations because of we have to take a decision of regarding the pregnancy. So at times it becomes very difficult interpreting these results, especially when it's a variant of unknown significance. Parents should be counseled first about these limitations, about the possible need of doing further tests. And finally, in case of doubt, we should be open to discussing these cases with experienced colleagues who have expertise in that field, or maybe in incredibly difficult cases, you may form a board in the hospital which involve the obstetrician, the geneticist, the pediatrician, the neonatologist, so that a combined decision may be made, because at times there might be difficult, challenging cases, and a single clinician taking a decision might be hard. Because there are instances where you get a variant of unknown significance. Now you don't know what the outcome will be, and there have been instances where the patients have been counseled that the outcome is going to be normal, it's just going to be a mild disorder, and then the child had very severe symptoms and things like that. So I think these all aspects should be covered in
Thank you, Doctor. The next panelist is Dr. Janani. Welcome to the panel discussion. And with your experience in genetic counseling, how do you stand, or how do you recommend the healthcare professionals, go through the maze of and approaches, or what are test to order for individual cases, and what approaches you find most effective in helping parents make informed decisions? It's a tough one. It's not easy, but I would like you to share your experience, where you find obstacles and challenges. And sometimes it is easy, but in medical profession, nothing is easy. So thank you. Please share your experience. Again, 6 minutes, please.
Thank you, sir. That was a very challenging question, and something which we are facing on an everyday practice also. Sir's question is like the kind of challenges which we face, communicating with the patient and the clinician, and also helping them give the correct management protocol. So I had 5 speakers before me who were talking about a lot of tests and the correct tests to choose, and how the patient, their stories and all. But everywhere I noticed that it was really nice also to get acknowledged, but every clinician over here acknowledged that the patient communication what is being done in a test, what is not being done in a test, what they are being tested for, what is happening behind. It has to be effectively communicated, that is the pre-test and post-test, just like ma'am had said. So that's the first step, which we as genetic counselors have achieved, that, we have made, this practice is there outside India, it is not there in India, but currently I'm happy that it is being acknowledged, and I think so the first barrier is being crossed here, where this acknowledgement comes in, and then we have patients for the pre-test and post-test. And secondly, while doing a pre-test, we also look at 3-generation pedigree, and we do a risk analysis, and we would be able to let the clinician know what else might be there, because very straightforwardly, in my experience, I've also seen a couple who has a first child of Down syndrome, but they've not told it to the clinician, they've not told it to the genetic counselor, and they're having a second child who with a high NT, and the soft markers were all abnormal. So, after sitting with that patient for an hour, after that, the patient opened up, after sending the mother out, sending everybody out, then only the couple remained, and then they told me that they already have a Down syndrome baby. So, this is where, genetic counseling or the pre-test genetic counseling would help us get more information about the family, and it might help us, to maybe choose the right test also, because a lot of information is there within the family, given the consanguinity in our country. But I'm seeing a change now, just like Rajivi ma'am said, 2 different backgrounds, ethnic backgrounds, and then she had a common disorder. Right now, out of if I see 10 cases, 5 are consanguineous and 5 are non-consanguineous. Equally, there are autosomal recessive carriers. Even though they're not consanguineous, we're seeing a lot of autosomal recessive carriers without a consanguinity in them. So, there again, but we would have hints from the family, like, they might have recurrent pregnancy losses, or they might have some cousins or some. Usually when you ask family history, they say, I'm good, my brother is good, my parents are good. They don't understand that the first degree relations and second degree relatives are also important. They also share some part of their genetics. So this is what happens in the pre-test counseling part. So this is where we do a lot of communication, and we also ensure that, like sir was just telling, they have done NIPS and they think the whole genetic screening is done, but then a lot of single gene disorders we are picking up. And yes, VUS, the variants of uncertain significance, is a very big issue over here, but with expertise, like we do have a few trained geneticists. So we have guidelines given by the ACMG to reclassify the variants of uncertain significance. So as a geneticist, when I sit with the patient, there are a lot of, there are 5 criteria given by ACMG, which helps us, to reclassify a variant, make it more actionable for the family, and then give a management plan to that. We've been doing it, and we've also stopped, sometimes once I had a couple who came for a second opinion after, they were asked about their baby. But then we found out from further, fetal scans, and then anomaly scans, and then further genetic testing. And then we usually have a board of doctors for the management plan. Once that was done, it was a manageable disorder. The baby is almost 1.5 years old now. So it was a baby which was asked to be aborted. So the baby is good now. So all this happens when we have a team of geneticists, genetic counselors, the clinicians, the pediatrician, neonatologists, everybody sit together. And then, definitely we could take really good information. We could take decisions for the mother, the baby, the growing fetus, and the family also. So this is something which I would like to share.
Thank you, and thanks for all the panelists keeping on time. And as we move on, our next panelist is Dr. Deepa. And what are the challenges you face in prenatal genetic testing? As a gynecologist and obstetrician, what have you encountered with respect to prenatal genetic testing? Could you share any technical or patient-centric challenges, please?
Thank you, sir, and thank you for the opportunity. And it's nice being with a genetist. And see, I'm an obstetrician working in a private sector. Generally, in my antenatal, in my clinic itself, I see almost 10 to 12 antenatal patients per day. Out of which we'll be seeing in the first trimester is almost like 3, 4 or 5. So I have a plenty of time to have a detailed history. If they are coming into the history of recurrent pregnancy loss, bad obstetric history or anything, I'll directly put them to the genetic testing. If they come before pregnancy, that's glad. But even if they come during pregnancy, if they have a very bad obstetric outcomes or very bad if they suspected any genetic things, so I'll put them into the genetic counseling separately. So they go through the genetic and they have a detailed pedigree analysis and other things. And coming to the low risk population, which I am seeing, out of it, I'll put them all for the screening in the first trimester. It's a NT scan plus double marker. First trimester screening test. Now we are adding, including a preeclampsia test screening. So by adding preeclampsia test screening, other than that routine down screening, I'm getting a possibility of picking up the early preeclampsia, the risk for preeclampsia in pregnancy. So this gives me an opportunity to put the patients on aspirins, ecospirins, so that preventing small babies as well as preventing. So that's the advantage. But if suppose if the lady with age of more than 37 years, I'll give an option. They either choose an FTS or they either choose an NAPT directly, or they can directly go for direct invasive testings because they involve coming to the high risk groups considering the down screening test. So I have full luxury. So NAPT for the limitations and everything, we'll do the detailed counseling in the beginnings, and it's 99. It's been vastly discussed here now. So coming to the people's working in majority of pregnancies, deliveries happening in government sectors. 70% of pregnancies happening in and Tamil Nadu. We have an extreme good healthcare systems, good medical facilities, and they do have RCH registrations. In fact, see a population of 300 pregnant women going to in a antenatal clinic per day. Out of it, almost 50 will be the first trimester woman. So what modality they can give? So whether we need actually a system. Right now, the system what's going on in our Tamil Nadu government is we will be seeing most of the women in first trimester will be in PHCs, community service, as well as urban health centers. So there is a good system of risk scorings. They do have the checklist, and they send all the first trimester for NT scan. That's a base test they will be doing. High risk, they will be directly sending to the tertiary care and government hospitals, where again the NT scan is the only available options. They routinely don't do FTS to my knowledge. If they have any other high risk like above 37 age, consanguinate marriage, or if they have a previous bad history, then they subject the woman. Still an FTS itself is a high risk based screening test in the government sector where majority of pregnancy delivery is happening. So, but still NT gives 80%. And are they missing any Downs babies? We don't know, because even if they miss in the first trimester, second trimester, those pregnant ladies are going to the same institute for the deliveries. So that statistics and registry we have to check on how good their NT scans alone. So for them, probably for all the women, if you give an option of giving a routine screening, NAPT is the cheapest formers. So that will give 99% screening test. That the lab persons have to take over some government sectors and do it. Maybe that may be the options. NT scans, we still depend upon the fetal medicine specialist and detailed scan radiologists who are specialists in NT. So that validity also we have to check on it. So in that conditions, I would prefer NAPT as an universal to give it. And coming to the hearing about the carrier testings, all the girl children before they get married, if they go to the 500 genetic carrier testers, then we can come out of all this screening tests and pick up early diseases. Thank you.
How to proceed, because the fetal fraction I think was less than 4%, and they have written it is a no-call test, neither they have given as positive or negative.
Yeah.
The next panelist is Dr. Bhavani Srinivasan. We'd like to hear from you the landscape of prenatal genetic testing in the USA. Incidentally, she's my wife. So, thank you.
Thank you. At the outset, I'd like to thank Vinayaka Medical Research Foundation for setting up this conference. It's a much needed topic, and everybody needs to know what's out there, what's available, what they can access, and how they can access it. So thank you very much for doing that. And I'm happy that I'm having this conference in India, because this is my Janma Bhumi, although the US has been my Karma Bhumi, and this is one way of giving back. So thank you for that. So we should talk about genetic testing in the US. A little bit of history here. Genetic testing, there was a registry which was created in 2008. And after that, it's been extremely highly regulated, as you might imagine. Any testing that has to be done has to go through CLIA lab, which is a clinical lab improvement amendment facility. And there are 4 categories of tests which they all look for and which they screen for. And it can be diagnostic, it can be pre-symptomatic, it can be a screening test, or it can be risk assessment test. So all these 4 categories are taken care of in the tests which are administered there. And I should tell you that this has increased, and it has grown proportionately over the last few years, in the last decade, I should say. The modalities which I mentioned, 2, 3, and 4, they were available from 2012 to 2015. But from 2015, the diagnostic angle really took over, and that's taken precedence at this time. And I think 81% of tests in the US are diagnostic now from all the 250 labs which were put into play after that. And the different types of testing, many of the speakers have talked about single gene testing. And looking at a person, as we heard from different speakers, it doesn't matter. Just looking at a person, you can't tell what's lurking in their background. On a personal experience, I had a nurse whose nephew was a 6-foot-tall basketball player, African American, and he fell in love with this Caucasian girl who was Polish ancestry, and their first child happened to have Werning Hoffman. And that child lasted for about 3 or 4 months. And when they did go in for testing, they found that they both carried the recessive gene. So how random is that? So now, actually, anytime I see young couples, the norm should be, I think, that when they tie the knot, the next thing should be, please have a testing done. And this, there are a number of carrier screens out there. One was a family prep test which came out in 2009, and it tested for over 100 autosomal single gene recessive disorders. So it gave you a lot of information in that one test. And talk about non-invasive testing. This test used saliva, not even blood. So the way the kit would come to prospective parents, it was about the size of a cigar box, and they would get sputum. It would be up to a particular level in that little flask which was enclosed, and the reagent was in the cap. They would shake it up, they would put it back in the cigar box, and they would FedEx it to the lab. And in about 10 days, they would get the results back, and whether or not they had any of these screens. And so this is what I think that they should be doing right immediately after they they get married. The other type of genes is the testing that we were talking about. You have panel testing and large-scale testing. I think a lot of Dr. Rajivi has also already spoken about exome testing and genome testing, so I don't have to mention that. But early detection is a must. And as a pediatrician, I'm in the unenviable position of locking the stable door after the horse has been stolen. Because they come to me and they already have a child who's affected, and that's why they seek medical attention and they seek medical information at that point. So, one wishes one could turn the clock back, but at least one can ensure that that particular child whom they are about to have is a normal child. So whether they have to, because of these screening tests, whether they have to go for IVF or whether they have to go, for surrogate pregnancy, whatever their choice is, but at least we give them that choice to have a normal child, which I think is so very important. And we were talking about all the trisomies, and we're talking about sex chromosome abnormalities, like Turner's. A lot of these tests do show Turner's, and they also show Klinefelter's. And one other test which has nothing to do with the sex chromosomes, but which is also fairly rare, is Noonan syndrome. And that, a lot of research is now being done on Noonan's children, because it's a whole spectrum disorder. You can have children who are severely affected with kidney and cardiac abnormalities, and to the other end of the spectrum where they look and behave in an almost normal manner. So unless you know, the parents are nonplussed as to why the child is always sick or always having an issue, till they get the genetic test done and then they find out. And one of the other tests which can be discovered by NIPT is achondroplasia. So that's another entity which should be looked for. And NIPT, the beauty of it is, as Dr. Rajivi had mentioned earlier, that you can do it at 9 or 10 weeks. So you don't have to wait for the amniotic fluid to generate and then take the amniotic fluid to test. So 9 to 10 weeks, one can get the mother's serum, one can spin it down and check it out. There's another test. There's one company which actually takes the mother's urine and checks that for the fetal cells in the urine itself. So the things are coming a long way. When I started practicing, I can tell you, anytime I wanted to do a genetic testing on any of the kids in my practice for suspected syndromes, it cost thousands of dollars. It really did. Whether, if I suspect a child of having Fragile X, for example, that was $800 to $900 right there. And if you suspected something else, the price tag came along with that. And now the price has been whittled down. It is the family prep test, which I mentioned to you, was initially offered at $350 with a 10-day turnaround time and results. And subsequently, the price on that went down as well to $100. So it's within the purview of everyone there. And most insurances were covering it because it was in their interest to have a healthy offspring. So the insurance companies would not be obliged to be footing the bill for a long-term stay in the newborn intensive care unit and care thereafter. So this is the state of testing in the US. And I know India is going to get on board, and I know we'll bring all these tests here. And this is to having a healthy baby with healthy parents. Thank you.
First of all, I want to thank all the panelists, and I think Dr. Rajivi Madan Kumar wants to share one or two more points before she heads to the OR. So, Dr. Rajivi, please add your comments. Oh. How do you unmute?
Can you hear me?
Yes.
Oh, okay, yeah. Couple of things, for about the variant of unknown significance. So obviously these results are going to be after invasive testing on amniocentesis or CVS, right? So I would suggest before you do any invasive testing and somebody is looking for a microarray result, doing microarray on a specimen, always tell them there is going to be VOUS. Obviously, it's self-explanatory. It's like VOUS. It's uncertain significance. You got to tell them, document that you are going to see VOUS in the results, which make no impact. So if you have a phenotype of the baby and you do a testing, you do microarray, if you do not get an explanation for the phenotype in the results, and if you get something else, which is a VOUS, I wouldn't recommend anything except that reassure them. You just need to document before the testing that you may get VOUSs, and after the results, you got to document. And this way, you can avoid legal implications. So that's my suggestion for whoever like dealing with the patients like that. Just document before and after the results, and also tell them it's a VOUS, no uncertain significance. We went through all these genome browsers, and we don't see an explanation for this VOUS. The phenotype baby is going to have may not be from this VOUS. Just document it. That's the one way that you can protect yourself. And coming to achondroplasia, there is an NIPS test for achondroplasia now as well. It's called Vistara. It's actually one company is doing some companies. We are using a NIPS by a specific company for like 40 single gene diseases. It's been pretty good. We actually had a few patients with skeletal dysplasia, and it actually picked up correctly. And they are not 100% tests; they are all screening tests. People have to understand that. Thank you so much.
Thank you, Dr. Rajivi. I think Alka Sehgal is coming online. Is from AVMC. Is she joining us? Can we connect her, please? Dr.
Yeah. Very good evening to everyone. It's been a one. Am I audible?
Yeah, but
am I audible?
Yes.
Very good evening to everyone. It was a wonderful panel discussion, and it is heartening to see that people are now specializing in fetal medicine, although this is not a separate course. But in India, we now have a lot of fellowships and DNB courses, and therefore we have specializations available. But unfortunately, mostly in the private practice. I can see most of the panelists are also from there. I would just like to share, because way back, Mr. Srinivasan, you will be pleased to know that I was the pioneer of starting universal screening for aneuploidies in northern part of India in my medical college as a universal screening. And the first, I got the award for this in 2007 by no one less than the father of fetal medicine, Mr. Nicolaides. And at that time, the topic for my discussion was if buts, lacunae, and remedies of establishing universal screening at a level of a developing, at a level of a medical college in a developing country. And mine is a government medical college. And we had plenty of support from the institute. Although we have a premium institute of postgraduate institute of medical sciences in the same city, 8 kilometers away, we got a lot of support from the Chandigarh administration. Now, what I wanted to just share was that for some reasons, the data, I could hear Rajiv sharing that how the data should be maintained. Unfortunately, that's mostly, in the initial stages, there were many hiccups. And by the time we started maintaining the data, you would be surprised, this is one of the largest data in India of about 51,000 women having been screened for aneuploidies. But the data was, the pickup rate was extremely poor. We had about 27 Downs babies picked up in 51,000, which the incidence would, the specificity and sensitivity if we calculated would be very low. But the tragedy was that, as somebody shared earlier, that most of the time women in pregnancy turn up in government setups from rural setups and other places a little late, and most of these were triple test. So almost 70% of them were triple test. And initially, when we started doing the dual test also, NT was not available. and then standardization of the NT from various, radiological centers, because one center from medical college would not be able to offer the NT. So we started getting the NT done from outside, and somehow we feel that the standardization was not possible. See, I can see that from the private setups, the number of patients you get is very low. But in the government setups, because the number of patients who turn up in the first trimester also, now, of course, in the first trimester in Chandigarh, the setup is very different. It's almost like Singapore, Union Territory. We have a good antenatal care, and we have a good setup to screen early. But this was one problem. And the second problem was, when I saw that the sensitivity is very poor, I calculated the possibility of introducing NIPT as a screening procedure. But then that does not turn out to be cost effective, at least in a government setup. So that is where, we had to compromise with the screening. The third thing is the invasive procedures. Now, we did have setups with some private agencies, which they offer NIPT as a first test, and then they, for about 8,000 rupees, which not every government patient can, patient who's coming to a government setup can afford, but still, it was something. In that 8,000, if NIPT was positive, the amniocentesis and the culture would be free of cost. So we did try our level best for all this, but still, personally, I think we are far, far from what is being spoken about from the private setups, and especially from developed countries. So this is what I just wanted to share. There is a need for some kind of a coordination, because we have a lot of, we can say, we have a lot of scope of what this whole panel discussion is all about. The second test which we introduced at that time was as a small project, as a research project, nest and hemoglobinopathies by manual methods, which was again, we did try in about 2007 or 2008. Now, of course, electrophoresis is being done as a routine in my college. But I'm very sure this is one of a unique medical college which is offering so much. Being a union territory, in government setups, I think, sir, if possible, we can think of some kind of a coordination, because I'm sure when the things become available, they will definitely become more cost effective also. So there is a lot of scope in a developing country, provided we get some kind of a coordination or collaboration from developed countries.
Thank you, Dr. Thank you, Dr. Sehgal. Let's give a big round of applause for all the panelists. I think there will be some Q&A from some of the panelists. If anybody is interested, please raise your hand. And the take-home message, as I understand, is there is no such thing as a normal patient or a normal person. We all are carriers of some traits or diseases of some kind, except it doesn't unfold in the early stages or late stages. But we inherit the genes from our parents, the good genes and not so good genes. If you look at from the child's point of view, some of them manifest early, and some of them in the developmental abnormalities, and some of them are rapidly fatal. So I think there was a mention about pricing and the whole lot, but now if you look at the VCR, when VCR was first came in, it was about $400, $500 equivalent. Now if you give VCR, nobody wants to take it. So as the technology improves, the price also comes down. So that is how one has to look at it. Yes, and the same thing, like all the youngsters almost have an iPhone or an Android, whatever phone is, the state-of-the-art technology, which becomes obsolete after 3 years. Whereas these tests are good for life, and at the most is not like doing a cholesterol and blood sugar every year or your vitamin D level every year or every 6 months. So anyway, this is something for you to take over. I think the time has come for awareness in the public as well as among the physicians, and I think we are in the right track, and thanks to AVMC and Dr. Ganesan and his team to putting together to start. It's going to be a big bang. Thank you again, and thanks for any question. And yes, please tell your name and whom do you want to answer a question from. Come, you can come here.
Good evening, everyone. I'm Dr. Meenakshi Pandey. I'm a final year obstetrics and gynecology PG in AVMC. My panel is basically for my question is basically for all of us in the panel. As we all know, we are basically living in the era of miracles. You're finding microscopic things where things were not even thought to be there. So all these new genetic tests are coming, the genome sequencing is coming, everything new is coming, where we are looking at the minute and inside things of inside. But still the karyotyping is being performed. The classical standard karyotyping that was performed, it is still being performed. Is there a specific thing that no other test can provide that the karyotyping is still providing? Is that a way, or we are just holding on to the rules?
Yes, karyotyping is gold standard for some. For example, trisomies, monosomies, balanced translocations, all this only karyotyping would be able to tell you. You will not be able to pick it up through any of the advanced testing. So, for example, if you have to identify Down syndrome, you cannot do whole exome and identify a Down syndrome baby at all. We do have a lot of other syndromes in the same spectrum, which a whole exome or a microarray will not be able to pick up. You would definitely have to do a karyotyping for that, and that is a basic screening test, and it is mandatory in some places.
With regard to use of karyotype, one important aspect I wanted to highlight was I've seen many cases where a lady will come with recurrent pregnancy losses, and she has been advised to do a chromosomal microarray along with a partner. That is completely wrong, because a chromosomal microarray is not going to pick up your balanced translocations, which might lead to recurrent pregnancy losses. That situation, you should be advising a karyotype in the couple, not a chromosomal microarray. So that, because it's not going to pick up balanced translocations. That's only looking for unbalanced translocations, which is not going to be the case for the parents. So definitely karyotype is important. And
this is Rajini from New York. I totally agree with the discussion. As a PG, as a postgraduate student, you have to understand, like, you have to always step up, like, low to high. Always check the chromosomes karyotype first, then go for microarray if the karyotype is normal, that you can get an explanation for the phenotype. Do the karyotype, then go for microarray. If the microarray doesn't give an explanation, then go for exome and genome. I know we spoke about all of those, but the understanding that karyotype is the gold standard to start with.
Meenakshi, the microarray you're finding out, and it happens to be a trisomy 21. But the mode of inheritance can be found out only by your conventional karyotyping. Why we are doing that? To find out the rate of recurrence. Supposing if the trisomy 21 has occurred because of some defect, non-disjunction, the chance of recurrence is just 1%. When it happens to be a Robertsonian translocation, and if the mother happens to be a carrier, the chance of recurrence is 12%. And if the father is a carrier, it is 3%. In the rare incident of 21-21 translocation, the chance of recurrence is 100%. And that is the reason why we are asking to do a conventional karyotyping to find out the type of inheritance for the consecutive pregnancies. That comes by the mode of trisomy 21, whether it is due to a non-disjunction or whether it is due to a Robertsonian translocation, can be picked out only by your conventional karyotyping. Anything more you can add?
See, we are living in the era of ART, where we come across multiple pregnancy, that is at least twin pregnancy. what is that screening test? It can be that is non-invasive screening test we can do certain extent. Okay. What is the confirmation? Because I have an experience where a patient had a twin gestation. Okay. So we did the conventional NT, everything was done. After that, at around 24 weeks, I started noticing one baby having a short femur. Okay, and then we confirmed the Mediscan, they diagnosed as achondroplasia. She had actually 3 missed abortion earlier. So what was my thing? No, actually I continued the pregnancy because at least I'll give her one normal child. Okay, so in those cases, we are coming across cases like this. In those cases, what is the role of our genetic testing? How they can help?
Madam, if it happens to be a monochorionic twin, the chances of trisomy 21 will be given as one thing only because it develops from a single zygote. Whereas if it happens to be a dichorionic twin, the chances of trisomy 21 will be given separately for A twin and for the B twin. And if it happens, we are measuring the NT for the monochorionic twin, and when you're going to give the NT, it will be the average of the 2 babies when you're going to, they will report. Whereas if you're going to get the NT for the dichorionic, it will be written separately. A baby has got an NT like this and B baby has got an NT like this. And in a single fetal demise, the NIPT is of no use, madam, because it will interfere with your test and the fetal cell-free DNA will not give you a proper interpretation if it happens to be a vanishing twin or a single fetal demise. This is as far as I know. I think the geneticists can throw some light.
Okay. And survived the twin. Actually, she developed the girl baby. At the age of 7 years, the child developed insulin-dependent diabetes.
All non-skeletal dysplasias are lethal, madam. Achondroplasia, they can survive. They can survive.
No, baby died. Okay.
They are compatible with survival. Yeah.
Pregnancy because we were had. One child was normal, so I was forced to take it up to term and delivered her. Okay. So the child, achondroplastic child, died after 2 days. The child which survived died, I don't know what reason. Okay, not because of the achondroplasia, maybe some other reason. Okay, that's the surviving child is having a IDDM.
So, ma'am, in twins, like we screened only for trisomy. So, these kind of evolving problems, we cannot, when we have to go do by scan and then go for a short femur and go through the protocol of short femur, what we have to investigate.
Such situations where one twin is symptomatic and others not, we can do a amniocentesis from the affected twin and a diagnostic genetic testing, and then if it comes positive, there are options of radiofrequency ablation to terminate the affected twin and allow the other one. But generally, we do test both.
Yes. So, ma'am's question was how genetic testing can help in twins, and ma'am's question aligns with it. Then she had a no call. So NIPS has certain limitations when the BMI is high. So majorly it depends on the cell fraction. So when the BMI is high, the circumference is high, then the cell fraction is less. And the same thing for the twins also. We might have mixture of DNA. The pickup is very difficult on the output machine. So it is always confusing. So when we have twins or when we have a very high BMI mother, we don't recommend an NIPS. There are cutoffs for it. Okay, so all this criteria has to be met before an NIPS sample is given. So when we have twins, invasive is the best method. And
that we can still offer NIPT for twins. For monochorionic, it's simple. We can offer, the detection rate is as good as a singleton, mostly 99. Dichorionic twins is still 96%. The paper in 2022 it came out. But only thing is we don't know from which fetus. if it comes positive, then we don't know, we have to confirm with invasive testing for both the fetuses. If NIPS is negative, it's still reassuring because most of the ART patients, they don't go for invasive testing. So in that case, you can still offer an NIPS.
Thank you. The interest is great, but the time is short. So I think we will be here for rest of the night, and we'll keep on asking questions from the panelists. And again, once again, I request a round of applause for all the panelists, and especially to Dr. Ganesan and the Vice Chancellor and the AVMC team. And where is... oh, there you are. Okay. She will give you the concluding remarks.
Hi, this is Dr. Rajivi. Can you hear me? Yes. Yeah, okay, yeah. Twins definitely can do NIPS. You can do NIPS with understanding if it is monochorionic on sonogram. It is it's good, but there are some specific NIPS tests that they can even do zygosity testing. So you can see that they're dizygotic, monozygotic by NIPS. And out of 20% of all dichorionic twins are monozygotic anyway, so you definitely can do NIPS. But if the one baby has increased nuchal, always offer invasive testing. And you can do selective reduction, with the KCL. So definitely NIPS can be offered for twins.
Thank you, Dr. Rajivi. Thank you, sir, and the panelists. It was a very informative discussion, enlightening the audience. Now I would like to invite our Honorable Chancellor, Dr. A.S. Ganesan, to honor the distinguished guests and experts of this roundtable conference. Now I would like to invite Dr. Anjalakshi Chandrasekhar, the chief guest of the session today.